Okay, now that we have learned all about ossification and bone elongation and bone remodeling, let's learn a little bit what happens to calcium both in and out of the bone, as well as some other chemicals. So let's stop and think for a second what is actually happening in bone when we are depositing and resorbing minerals. So starting first with the osteoblasts. The osteoblasts are the bone builders. And so they are responsible, once they have secreted the osteoid and laid the collagen and the protein fibers in it, then what happens is they are going to be secreting minerals, and the minerals actually get deposited on the collagen fibers. They're not dissolved in the osteoid matrix itself. They're on the collagen, and that's where they will harden. And when we're talking about minerals in the bone, typically we're talking about calcium, and the most common thing that the calcium is going to be bound to is phosphorus. And there's a couple of different ways of it bonding. In other words, there's a couple of different chemicals that are formed, but the one that is the most common and most abundant is called hydroxyapatite. So we get hydroxyapatite crystals on the collagen. I want to point out the spelling of the word apatite is not like the type of appetite you have when you're hungry, which would be an APE tite. This is an APA, appetite. Okay. So that's what the osteoblasts are doing. Once it is mineralized, then the osteoblasts are trapped. They are, as the slide says, buried alive, surrounded by their hot tub, the lacuna. And then for when we need to get the calcium out of bone, that process is called resorption with a P and not a B. So it's what happens here, it involves the osteoclast. Okay. So you have pictures of the osteoclast here on the left side, and notice the ruffled borders are the borders that are sitting next to the bone. And so the osteoclast recognizes that in the circulating blood, the calcium levels have fallen, okay? You're at the lowest end of the normal range for calcium levels. And that's what triggers the ruffled edge to secrete hydrogen ions. And then the chloride ion follows it. And that's how you get the hydrochloric acid, the HCl. Now, HCl has a really low pH by itself. It's about 1 or 2, but then when you put it with the osteoid, basically the overall pH is around 4, which is still pretty acidic. And it's acidic enough to dissolve the hydroxyapatite crystals off of the collagen. So at this point, the osteoclast is also secreting an enzyme, which is a protease. So anytime you see that suffix ase, that tells you it's an enzyme, and a protease is an enzyme that breaks down proteins. And in this case, the protein we're talking about is collagen. Okay. And so this protease, this collagenase, is going to break down the collagen, and so then everything can undergo phagocytosis. So when you look at this, when there is pressure on a bone, what normally happens is the osteoclasts become active at this site of pressure, and they will dissolve the bone adjacent to the pressure. And so if you stop and think for a second, remember when you had braces on and they were tightening your braces, basically they were pulling a tooth and pushing against bone on one side, which put pressure on that. So then osteoclasts right next to your tooth would dissolve the bone. And then what happened was that made that there was no pressure on the other side because your tooth was no longer in contact with the bone on the other side. So then the osteoblasts would come into the area of low pressure, which is behind it, and they would bring on the new bone formation. So when we're talking about mineral deposition and resorption, it's not the deposition that happens first and then the resorption. It's the resorption that happens first, and then the minerals come in and fill in that space. And so that's how that bone remodeling is going to happen. All right. So in order to understand calcium, the first thing you've got to understand is that calcium is not just for bones. And in fact, when you ask scientists and healthcare providers the importance of calcium, making strong bones may be the slogan for Wonder Bread, but it's not the slogan for medicine because that's really low on the list of importance. Okay. So for instance, the phosphorus, it's found in DNA, it's found in RNA, it's found in ATP, it's found in your phospholipid bilayers of every single membrane in your body. Yes, it mineralizes your bones and also mineralizes your teeth, and it helps with the pH. But it's got, as you can see, that ATP, DNA, RNA, that is even more important. Similarly, calcium has more important things than bone. Neurons cannot send their signals if they don't have calcium. Muscles cannot contract without calcium. That means your heart can't beat without calcium. Your blood can't clot without calcium. Signals between cells, there's a lot of second messengers that require calcium. There's some third messengers as well. Some enzymes can't work without calcium. So as you can see, these are really important for our normal biological processes, and having that hydroxyapatite, that's just kind of like, think of that as a spare supermarket, that whenever we need calcium and phosphorus, we don't have enough in our blood, we can go to that supermarket, the bone, and take the calcium and phosphorus out of there. And so that gives us to calcium homeostasis. I'm going to talk about calcium first because it's by far the more important one, and then at the end, I'll talk about phosphorus. So yes, 99% of our calcium's in our bones. It's very stable. It's that hydroxyapatite crystal. It is not easily exchanged. The only way you're going to get it out is to get those osteoclasts to destroy the bone. And so over the entire course of a year, about 20% of our calcium is exchanged, where we take calcium out and then we'll put some more back in. And so we are constantly dealing with our blood calcium levels. When they're high, the high end of normal, we deposit in the bone. And then when they're at the low end of normal, we take it out of the bone. And so we're doing this all year, all day, every day. Okay. So when we have calcium in our blood, it falls into two big pools. I know the diagram is showing three, but it's really two big pools. About half of it, slightly under half of it, is as the calcium ion, the +2 charge. Okay. This is the type of calcium that's biologically active that we can use for all of those processes I was talking about that we needed calcium for. The other 50% is already pre-bound to proteins or other chemicals, so it's not physiologically active. However, it is a reservoir that we can take some out for immediate use. So we don't have to wait, oh, how long is it going to take that little piece of bone to break down? Oh, I'm sorry, you can't have any calcium for half an hour. It doesn't quite work like that. Okay. So a couple of terms I need to introduce is, let's talk about the suffix first. Anytime you see emia, that is telling you it's the blood concentration. It's something to do with blood. So calcemia has to do with the blood concentration of calcium. So hypocalcemia means we have low blood calcium, and hypercalcemia means we have high blood calcium levels. Okay. So you can have rising calcium levels and still be normal, and you can have falling levels and still be normal. But if you get below whatever the bottom line is, then you're hypocalcemic, and if you're above, you're hypercalcemic. So why is it bad to be too low or too high, or why do we really deal with this all the time? If your calcium levels are low, it can cause your muscles to go into a contraction from which they cannot be released, okay? So you can get muscle spasms or go into tetany, like the disease tetanus. And if the calcium levels are too high, it does similar, something almost the opposite. If you recall, I said calcium was needed for neurons to send their signal. So the neuron cannot send the signal to the muscle for the muscle to contract. Plus the muscles aren't going to have the calcium enter them. So your muscles are going to become very weak. And so in addition to that, all the neurons in your brain aren't working normally. So you actually can become depressed. So that brings us to something called calcitriol. And I'll get to what calcitriol is in a second. But first, I need to talk a little bit about vitamin D and sunshine. The first thing I want to say is the vast majority of the people in the world are vitamin D deficient. We used to think that if you went outside for half an hour a day and got sun on your skin, that was enough to have normal vitamin D levels. Now we know that's not true. And about 80% of the American population is vitamin D deficient because our diets just can't help this. And also we don't go outside and sit in the sun anymore. We slather on sunscreen. And if you are darker complected or have more pigment in your skin, you have to be out a lot more than 15 minutes. All right. But let's pretend you've got that diet with good vitamin D in it. So you're ingesting vitamin D or you're taking your vitamin D little capsules, which are fine. And the other way is to expose your skin to UVB rays from sunlight. And what happens is a cholesterol-like compound in the skin changes to a pre-vitamin D compound. And then that pre-vitamin D compound, if you have like 3 days of this, will eventually become a vitamin, what's called vitamin D3, which is the same form of vitamin D3 that is in the food. Okay. So either of these two ways, you can get it into your blood. That's not vitamin D yet. This is vitamin D3. And so what vitamin D3 does is it has to travel in your blood, and the first place it has to go to your liver, where there's a hydroxyl group, an OH attached to it. After that, it then travels to your kidney, where another hydroxyl group is added onto. So if you have liver failure, you can't do the first step, and which you can't do the first step, you can't do the second. And if your liver is functioning fine, but you're in renal failure or dialysis, then you can't do the second step. So you have to ingest calcitriol, not the dietary vitamin D3. Okay. So assume your liver and your kidney are working fine. You've had these two hydroxyl groups added on as 1,25-dihydroxy vitamin D3. You don't have to know that word. The word for it, this is the active form of vitamin D, and that is what calcitriol is. Okay. So it's not calcitrol, it's calcitriol, because students for some reason like to leave out that I, and that makes it a totally different compound. Now we call this a vitamin because we call it the active form of vitamin D3, but it's going to act like a hormone in your body, which means it's going to travel in your blood until it finds cells that has receptors for it, and then it binds to those receptors and it causes something to happen to those cells. So what's going to happen? All right, so there's a picture here, and basically we're only going to be talking a little bit about the left side of this picture, and then later on we're going to talk about what's going on the right side of the picture on another slide or two, and then you can come back and look at this. All right, so what does calcitriol do? Well, the first thing it does is whatever dietary calcium you are ingesting, your 1.5 grams a day, or your measly little bits that you're getting, it's going to increase the amount of that that's absorbed and sent into your blood, thereby increasing your calcium pool. The second thing it's going to do, it's going to bind to osteoblasts. So the calcitriol binds to osteoblasts. Okay, and you're thinking, wait a second. We're trying to get calcium out of the bone, and that's the job of the osteoclast. And I go, I know, but I did not misspeak. It does not bind to an osteoclast. It binds to an osteoblast, okay, the bone builders. When it binds to the osteoblast, that makes the osteoblast produce a chemical messenger known as rankle, R-A-N-K-L, all caps. And what rankle does is it causes the formation of new osteoclasts, so it's really kind of a cool thing. We are going to have a receptor on a bone builder, which vitamin 3 can bind to, which then is going to cause the production of a bone destroyer. Okay. And so now that we have the new osteoclast formed, then the osteoclast will reabsorb the bone. So that's the second thing calcitriol does. And the third thing it does is it causes the calcium, whatever calcium might be in your kidneys, it's not going to end up in your urine. It's going to be sent back into your bloodstream. So that's vitamin D, the active form of vitamin D, calcitriol. Now, if you have a deficiency of vitamin D as a child, that is the disease called rickets. And so a lot of people have heard about rickets. If you haven't, asked your parents, because they probably have. And so this happens with severe vitamin D deficiency. And so if you take vitamin D deficiency, that means you can't absorb the calcium. So then if you don't absorb the calcium, that means you can't put the calcium down with the osteoblasts. Okay. So the osteoblasts, basically, because you have low calcium levels, you can never deposit it, so you never can get hydroxyapatite, so the bones are always going to be really soft. While you're crawling around on the floor as a 1-year-old, no problem. But as soon as you start doing weight bearing, the bones are so soft, they are going to start bending just from the weight of your body. So they bow under your weight bearing. So rickets is a severe vitamin D deficiency in children. Now, vitamin D deficiency in adults gives us a disease, but it's not called rickets. It's called osteomalacia. So once again, if you don't have any sun exposure, if you don't have any adequate intake, if you have that really bad kidney or liver disease I talked about, and then there's a couple of medications whose names you don't need to know, those are all causes of severe vitamin D deficiency. So bones are going to break easier. They're not going to bend as much because basically we have more weight on them. And so whereas in a child they might bow, in an adult they're just going to snap. Okay. And so you can have a lot of microfractures giving you a lot of bone pain and not know why that is, or causing gait problems or walking or muscle weakness because the muscles are pulling on the bone and the bone's getting microfractures. All right. So now that we understand about vitamin D and calcium, let's talk about how the body regulates your blood calcium levels. And the way it regulates, the major way it regulates is these two glands. So here in your neck where your windpipe is, sitting in front of the lower part of that and on both sides, there is a butterfly-shaped gland, that pink thing, called the thyroid gland. And I also want to point out on the back side of the thyroid gland, which does not mean back here, but it means still here in front of your neck, but like just back here. So on the back side of your thyroid gland, there's 1, 2, 3, 4, 5, 6, 7, up to 8 tiny little, and by tiny, I mean tiny, a couple millimeters in size. Can you even see it opening there in my finger? Yeah. See how tiny that is? Yeah. So that's how big they are in real life. They're really tiny, and they're on the side of the thyroid gland, so they're called parathyroid glands. So here is a histology picture, and I think you clearly can see that the thyroid gland tissue looks totally different than the parathyroid gland tissue in the upper right corner. And it shows you how the parathyroid gland is sitting right on the edge of the thyroid gland. All right, so let's talk about what the thyroid gland looks like. Okay, so in the thyroid gland, if you look at the big picture on the bottom right, you can see it looks like there are these islands of these pink stuff. And if you look at the bottom left, you can see that there is this pink stuff, which is labeled colloid, which is this proteinaceous stuff that's produced by cells. And you can see on the edges of the colloid that there are some cells there. And we actually have a couple of different types of cells. They're labeled here, but let's go up here to the drawing because it's easier to see in the drawing. So the colloid's in the middle, and the colloid is produced by these cells that surround it. And they are called follicular cells because this entire structure with the cells on the colloid, that's like called a little follicle. And so we've got one grouping over there. We have another grouping in the upper right, another grouping at the bottom right. And then in addition to that, we have these other pink cells. I don't know, they look kind of like rosebuds to me. I don't know why they did that. That are between these follicles. So they're next to the follicular cells. So these are called parafollicular cells. These actually have a lot of names. One name are parafollicular cells. Another name are C cells, and a third name is clear cells. Okay, so Those are the cells we're interested in talking about. This colloid and these follicular cells, that all has to do with thyroid hormone, which is an endocrine system topic, has nothing to do with calcium. So we are interested in these parafollicular cells, or these C cells, and what they're going to do. And the reason why we often call them C cells, because these cells release something called calcitonin. So if you go back, when I'm done talking about calcitonin, you go back a couple of slides. On the calcitriol slide at the bottom right, I had calcitriol on one side and calcitonin on the other side. So here's what happens. When you have high blood calcium levels, or in other words, hypercalcemia, these parafollicular cells, these C cells, release calcitonin. So what does calcitonin do? A couple of really important things. The first thing is it massively decreases osteoclasts. So it's preventing osteoclasts from breaking down bone. In fact, it's about 75% stopped within 15 minutes. Okay. So right there, if we're not breaking down bone, then we're not releasing any new calcium. So calcium level can't go any higher. In addition to this, it's going to stimulate osteoblasts so that we can take calcium out of the blood and now put it into the bone. So we're not releasing any from the bone, and we're adding more to the bone. In addition to that, it's going to make more calcium go out in your urine, and it's also going to prevent your intestines from absorbing the calcium. So here's a lovely little graphic showing all the things that calcitonin can do, which will eventually lower blood calcium levels, because we're taking calcium out of the blood and sending it into the bone and into the urine. So this is super important in children. Okay. And we like to talk about it a lot in adults. But in most adults, it's not that important unless you are a pregnant woman or you're a woman who is breastfeeding, in which case it's super important once again. Okay. But for the rest of us, it's not that effective at bringing your calcium levels back down to normal. All right. So in contrast to calcitonin, which has to do with high calcium levels, your body says, high calcium, oh no, calcitonin. In low calcium levels, the thyroid is not involved. The parathyroid gland is involved, and it releases a hormone called parathyroid hormone. And it's just a tiniest little drop in calcium levels that will double the amount of parathyroid hormone being kicked out. So it's super important. All right, so if we have low calcium levels, that makes you think we need to have osteoclasts become active, correct, and release it. So what does parathyroid do? Where is its receptor? It's on an osteoblast. So it has the same action just like that calcitriol did. It's going to bind to the osteoblast, make rankle, increase osteoclast formation, and thereby increase bone reabsorption and release calcium into the bloodstream. In addition to that, PTH causes calcium to go back into the bloodstream from the kidney, causes calcium to be absorbed from the GI tract, has you make even more calcitriol than you would have. Okay, so doing positive feedback to calcitriol synthesis, and it is inhibiting osteoblasts. Okay, so here's a nice little graphic for that. All right. So if we put those two things together, these are our major ways we regulate our calcium with hormones. When we are hypercalcemic, the thyroid gland says, oh no, we need calcitonin, which is going to increase your osteoblast activity, decrease your osteoclast activity, and have you excrete more calcium from your body and not absorb it. When we are hypocalcemic, the parathyroid gland will release parathyroid hormone, and we will increase osteoclast activity, decrease osteoblast activity, increase the calcium uptake from both the kidneys and the intestines. So make sure you understand these little feedback loops here, okay? And here is all of it. Another picture putting in the organ sites, and talk your way through this. Stop it at this point and talk your way through this. Okay. So now that you're done with calcium, let's talk about phosphate for a second. All right, unlike calcium, phosphate's really not regulated that much. And, you know, there's no hypophosphatemia, hyperphosphatemia that causes any really big phosphate disorders. Yes, a phosphorus intake has something to do with phosphorus absorption and from the gut and from the kidneys. Calcitriol, interestingly, increases the phosphate level. So not only are you making vitamin D for calcium, you're also increasing the phosphate, so the phosphate can bind to the calcium. So that's kind of cool. Other effectors that work on bone are a whole bunch of hormones. Cortisol, at times of stress, you're going to inhibit your osteoclast. You're not going to have the bone remodeling. Testosterone makes you make new bone. Estrogen is very interesting. Estrogen actually explains why women, I'll talk about it later when I talk about osteoporosis, okay? Growth hormone and thyroid hormones, which are normal hormones for growth, they both are going to have to do with making bone as well. And then, of course, chondroitin sulfate, which is involved, that requires vitamin A, and then the collagen, I think we talked about previously, that requires vitamin C for normal collagen cross-linking. So there's a lot of talk about, do people who drink Diet Coke have soft bones? Okay. And so there have been a lot of studies, and most of them like, yeah, no, not a whole lot. But there's one halfway decent study which shows that in women, only women, who consume at least 3 cans a day of cola products, okay? So not your Mountain Dew, not your root beer, it doesn't mean it's a brown soda, it means it's a cola product. If you consume at least 3 cans a day, you have such a significant amount of phosphorus that it binds to the dietary calcium and prevents it from being absorbed. Well, at least that's the theory, okay? And here's why I say bunk to this theory, because let's look at how much phosphorus is in one 12-ounce cola. It's 37 milligrams, and one Diet Cola is 32. This effect was not found in the Diet Cola drinkers, only the regular cola drinkers. So it's really 15 milligrams make a difference. And if it's really due to the phosphorus, then let's look at skim milk and yogurt, which has 10 times the amount of phosphorus. Granted, it also has some calcium, but let's just say the jury's still out. All right, and with that, we are done with this part, learning about calcium and all the things that go into keeping your bones strong. I want to thank you for all your hard work, and I will see you again soon, and we're going to come back with a more exciting topic next.